Hello everyone, welcome to PharmaGrid. So today we are going to learn about various disorders of the respiratory system and their treatment options. Asthma, chronic obstructive pulmonary disease, and allergic rhinitis are the commonly encountered respiratory disorders. Asthma is a chronic disease characterized by hyperresponsive airways that affects over 235 million patients worldwide. COPD is currently the fourth leading cause of death in the world and is predicted to become the third leading cause of death by 2030. Allergic rhinitis is a common chronic disease and is characterized by itchy, watery eyes, runny nose, and a non-productive cough that can significantly decrease the quality of life. Drugs used to treat respiratory conditions can be delivered topically to the nasal mucosa, inhaled into the lungs, or given orally or parenterally for systemic absorption. Local delivery methods such as nasal sprays or inhalers are preferred to target affected tissues while minimizing systemic adverse effects. First, we will discuss about asthma. Asthma is a chronic inflammatory disease of the airways characterized by episodes of acute bronchoconstriction which cause shortness of breath, cough, chest tightness, wheezing, and rapid respiration. So, asthma means it is a chronic inflammatory disease of the airways. It is characterized by episodes of acute bronchoconstriction. Bronchoconstriction means the bronchioles will become constricted. As a result, it will cause shortness of breath, cough, chest tightness, wheezing, and rapid respiration. Coming to the pathophysiology of asthma, airflow obstruction in asthma is due to bronchoconstriction that results from contraction of the bronchial smooth muscle, inflammation of the bronchial wall, and increased secretion of the mucus. Okay, so we have already mentioned that asthma is a chronic inflammatory disease and there will be bronchoconstriction. Okay, so as a result of this bronchoconstriction, there will be airflow obstruction in asthma. This bronchoconstriction is mainly due to the contraction of the bronchial smooth muscles and inflammation of the bronchial wall and due to increased mucus secretion. The underlying inflammation of the airways contributes to airway hyperresponsiveness, airflow limitation, respiratory symptoms, and disease chronicity. Asthma attacks may be triggered by exposure to allergens, exercise, stress, and respiratory infections. So these are the triggering factors for asthma. For examples include allergens, exercise, stress, and respiratory infections. And these triggering factors may differ depends upon the patients. Asthma can be episodic, means seasonal, or chronic in nature, which is known as perennial or status asthmaticus. After the trigger, mast cell degranulation releases mediators such as histamine, proteolytic enzymes, and inflammatory cytokines like tumor necrosis factor alpha. Okay, so as I have already mentioned, there are certain triggering factors for asthma depending upon the patients. So if a trigger occurs, what will happen? The mast cell degranulation will occur, and this as a result of this mast cell degranulation, there will be release of mediators such as histamine, proteolytic enzymes, and inflammatory cytokines like tumor necrosis factor alpha. The triggering inflammation also synthesizes slow releasing substances of anaphylaxis such as leukotrienes, prostaglandins, and platelet activating factor. Activation of gene responsive elements also causes the production of cytokines and chemokines. So all these mediators together contribute to the airway inflammation. The airway inflammatory phase leads to bronchoconstriction, edema, mucus secretion, vasodilatation, and activation of sensory nerves. A chronic inflammatory condition can lead to structural modifications in the airway epithelium, causing subepithelial fibrosis, smooth muscle hypertrophy, hyperplasia, angiogenesis, and hyperplasia of mucus secreting cells. Hyperplasia means it is an increased cell production in a normal tissue or organ, whereas this angiogenesis means it is a growth of blood vessels from the existing vasculature. And this, unlike chronic obstructive pulmonary disease, cystic fibrosis, and bronchitis, asthma is usually not a progressive disease. Okay, here you can see the structure of the respiratory system, and here you can see the difference between an asthmatic bronchiole and a normal bronchiole. In the normal bronchiole, there is no bronchoconstriction, no edema, and there is no mucus. But here you can see in the asthmatic bronchiole, what happens here? The bronchial smooth muscles got constricted. Okay, so as a result, there will be bronchoconstriction and the inflammation of the bronchial walls. And also, it is filled up with the mucus. Okay, so this is the features or this is the structure of an asthmatic bronchiole. So let's summarize the pathophysiology of asthma. It first starts with the triggering factor. Triggering factors can be any kind of allergen such as pollen, pet dander, dust, then exercise or stress. Suppose if an asthmatic patient come into contact with a triggering factor, it will lead to the release of a lot of inflammatory mediators. That will lead to airway inflammation, and this airway inflammation causes hypersecretion of mucus, then airway muscle constriction and the swelling bronchial membranes. All these features together contribute to narrow breathing passages, which will cause symptoms such as wheezing, cough, shortness of breath and chest tightness. Okay, in this diagram you can see the differences between normal airway, and asthmatic airway during an attack. Goals of therapy for asthma include, first of all, the triggering factors should be identified and avoided. Then if the patient is a smoker, smoking should be stopped and regular breathing exercises such as pranayama should be started. Physical activity and weight loss help in prevention of acute episodes of asthma. Drug therapy for long-term control of asthma is designed to reverse and prevent airway inflammation. The goals of asthma therapy are to decrease the intensity and frequency of asthma symptoms, prevent future exacerbations, and minimize limitations in activity related to asthma symptoms. Now let's see the classification of drugs used for the treatment of bronchial asthma. So the first category is bronchodilators, and these bronchodilators can be further subdivided into three, that is beta-2 sympathomimetics, methyl and anticholinergics. Beta-2 sympathomimetics include salbutamol, terbutaline, bambuterol, salmeterol and formoterol. Methyl examples include theophylline, aminophylline, choline theophylinate, hydroxyethyl theophylline and doxorubicin. Anticholinergics include ipratropium bromide and tiotropium bromide. Next category is leukotriene antagonist. Examples include montelukast and cefiolukast. Next one is mast cell stabilizers. The drugs include sodium chromoglycate and ketotifen. And another category of drugs that can be used for the treatment of bronchial asthma is corticosteroids, which can be further subdivided into systemic and inhalational corticosteroids. Systemic corticosteroids examples include hydrocortisone, prednisolone and other glucocorticoids. Inhalational corticosteroids include beclomethasone dipropionate, budesonide, fluticasone propionate, flunisolide and ciclesonide. And the last one is anti-immunoglobulin E antibody. The drug that comes under this category is omalizumab. First, we will start with bronchodilators, and among these bronchodilators, the first one is beta-2 adrenergic agonist. Quick relief. This short-acting beta-2 agonist have a rapid onset of action. Onset means the time at which a drug produces its action. The short-acting beta-2 agonist have got a rapid onset of action, which means within 5 to 30 minutes and provide relief for 4 to 6 hours. The direct-acting beta-2 selective agonist. Examples include salbutamol. Another name for salbutamol is albuterol, and next drug is terbutaline. They are used for symptomatic treatment of bronchospasm, providing quick relief of acute bronchoconstriction. Beta-2 agonists have no anti-inflammatory effects, and they should not be used as monotherapy for patients with persistent asthma. Monotherapy with a short-acting beta-2 agonist may be appropriate for patients with mild, intermittent asthma or exercise-induced bronchospasm. Adverse effects such as tachycardia, hyperglycemia, hypokalemia, hypomagnesemia, and beta-2 mediated skeletal muscle tremors are minimized with inhaled delivery versus systemic administration. Okay, so the first category is short-acting beta-2 agonist. Their feature is that they are mainly used for the quick relief of symptoms. Due to their rapid onset of action, their onset of action is within 5 to 30 minutes. The examples of short-acting beta-2 agonists include salbutamol and terbutaline, and they can be used only for the quick relief of symptoms. As they do not have anti-inflammatory activity, they cannot be used as monotherapy for patients with persistent asthma. Next, for the long-term control. Salmeterol and formoterol are long-acting beta-2 agonists and chemical analogues of salbutamol. They have got long duration of action, providing bronchodilation for at least 12 hours. Use of long-acting beta-2 agonist monotherapy is contraindicated, and long-acting beta-2 agonist should be used only in combination with an asthma controller medication such as an inhaled corticosteroid. Inhaled corticosteroids remains the long-term controllers of choice in asthma, and long-acting beta-2 agonists are considered to be useful adjunctive therapy for attaining control in moderate to severe asthma. Adverse effects of long-acting beta-2 agonists are similar to quick-acting beta-2 agonist. Bambuterol is a prodrug of terbutaline. Upon administration, it is slowly released over a period of 24 hours by pseudocholinesterase. So for quick relief of symptoms, we can use short-acting beta-2 agonists such as salbutamol and terbutaline because of their rapid onset of action, whereas salmeterol and formoterol are long-acting beta-2 agonists that can be used for long-term control. Both the short-acting beta-2 agonist and long-acting beta-2 agonist cannot be used as monotherapy as they do not have anti-inflammatory effects, and this long-acting beta-2 agonist should be used only in combination with an asthma controller medication such as an inhaled corticosteroids. And this inhaled corticosteroids remains the long-term controllers of choice in asthma. Next category of drugs is corticosteroids. These inhaled corticosteroids are the drugs of choice for long-term control or preventive options in patients with persistent asthma. Corticosteroids inhibit the release of arachidonic acid through inhibition of phospholipase A2, thereby producing direct anti-inflammatory properties in the airways. So the mechanism of action of corticosteroids is that they inhibit the release of arachidonic acid through the inhibition of phospholipase A2, thereby producing direct anti-inflammatory properties in the airways. To be effective in controlling inflammation, these agents must be used regularly. Okay, so this is a very important point. In order to control inflammation associated with this asthma, these corticosteroids must be used regularly. Treatment of exacerbations or severe persistent asthma may require the addition of a short course of oral or intravenous corticosteroids. Let's see how these corticosteroids acts on the lung. These drugs directly targets the underlying airway inflammation by decreasing the inflammatory cascade. By decreasing the inflammatory cascade means by decreasing the mediators responsible for causing this inflammation like eosinophils, macrophages and T lymphocytes, and also by reversing the mucosal edema, decreasing the permeability of capillaries and inhibiting the release of leukotrienes. Okay, so this mechanism of corticosteroids or how these corticosteroids act on the lungs means there are different mechanisms which includes decreasing the inflammatory cascade, which means decreasing the levels of eosinophils, macrophages and T lymphocytes, then reversing the mucosal edema or mucosal swelling, decreasing the permeability of the capillaries and inhibiting the release of leukotrienes. After several months of regular use, inhaled corticosteroids reduce the hyperresponsiveness of the airway smooth muscle to a variety of bronchoconstrictor stimuli such as allergens, irritants, cold air and exercise. Coming to the routes of administration, the first one is inhalation. Appropriate inhalation technique is critical to the success of therapy. It is very important for the pharmacist to counsel the patient regarding the appropriate inhalation technique. Next route is oral or systemic. Patients with a severe exacerbation of asthma, such as status asthmaticus, may require intravenous methyl prednisolone or oral prednisolone to reduce airway inflammation. In most cases, suppression of the hypothalamic pituitary adrenal cortex axis does not occur during the oral prednisone burst, which means short course, typically prescribed for an asthma exacerbation. Thus, a dose taper is unnecessary prior to discontinuation. We know that if these corticosteroids are used for a period of long term, it can cause suppression of the hypothalamic pituitary adrenal cortex axis. But it does not occur in this case if this oral prednisolone is used for a short period of time. Okay, if it is used for a short course of time for an asthma exacerbation, it would not cause any kind of hypothalamic pituitary adrenal cortex axis suppression. Thus, a dose taper is unnecessary prior to discontinuation. Adverse effects. Oral or parenteral corticosteroids have a variety of potentially serious adverse effects, whereas inhaled corticosteroids, particularly if used with a spacer, have few systemic effects. Okay, so this is one advantages associated with this inhaled route. Okay, it will cause only a very few systemic effects. But this inhaled corticosteroids deposition on the oral and laryngeal mucosa can cause oropharyngeal candidiasis. It is due to local immune suppression and hoarseness. Okay, so one of the most important adverse effect associated with the use of inhaled corticosteroids is oropharyngeal candidiasis. So in order to avoid this condition, patients should be instructed to rinse the mouth in a swish and spit method with water following use of the inhaler to decrease the chance of these adverse events. Okay, so the most important adverse effect associated with the use of inhaled corticosteroids is oropharyngeal candidiasis, and in order to avoid this condition, patients should be instructed to rinse the mouth in a swish and spit method with water following use of the inhaler, especially corticosteroid type of inhalers. Chronic maintenance with oral corticosteroids should be reserved for patients who are not controlled on an inhaled corticosteroids. Guidelines for the treatment of asthma. In all asthmatic patients, quick relief is provided by a short-acting beta-2 agonist as needed for symptoms. So here this asthma can be classified as grade 1, grade 2, grade 3 and grade 4 based on the symptoms as well as the bronchoconstrictive episodes. So grade 1 means mild intermittent type of asthma. So here for long-term control there is no need of any daily medication. For quick relief of symptoms we can use short-acting beta-2 agonist. The next one is grade 2 which is mild persistent type of asthma. And here for long-term control we can use low-dose inhaled corticosteroids, and for quick relief of symptoms we can use short-acting beta-2 agonist. Then coming to grade 3 is moderate persistent type of asthma. Here long-term control medication options include low-dose inhaled corticosteroids with long-acting beta-2 agonist, or medium-dose inhaled corticosteroids can be used as long-term treatment control options. Then for quick relief of symptoms, short-acting beta-2 agonist or inhaled corticosteroids, then formoterol combination is an alternative. Then grade 4 is severe persistent type of asthma, and here medium dose inhaled corticosteroids with long acting beta-2 agonist or high dose inhaled corticosteroids with long acting beta-2 agonist can be used as long term treatment control options. And for quick relief of symptoms we can use short acting beta-2 agonist or inhaled corticosteroid plus formoterol combination can be used as an alternative. And here you can see the stepwise approach to the management of asthma. So step 1, in step 1 there is no need of any controller choice. So let's start with low dose inhaled corticosteroids. Okay, and as needed you can use short acting beta-2 agonist as a reliever option. Then step 2 means preferred controller choice is low dose inhaled corticosteroids. Other controller options include leukotriene receptor antagonist or low dose theophylline. Then step 3 means you can add low-dose inhaled corticosteroids or long-acting beta-2 agonist. And in step 3, other controller options include medium or high-dose inhaled corticosteroids or low-dose inhaled corticosteroids plus leukotriene receptor antagonist or plus theophylline. Then step 4 means you can add medium or high-dose inhaled corticosteroids or long-acting beta-2 agonist. Other controller options include add ipratropium or tiotropium or high-dose inhaled corticosteroids plus leukotriene receptor antagonist or plus theophylline. Then step 5 means refer for add-on treatment with omalizumab. Omalizumab is a monoclonal antibody. And here in step 3, step 4 and step 5, you can use short-acting beta-2 agonist or low-dose inhaled corticosteroids with formoterol combination can be used as a reliever option. So before step up, we need to check the dose, device, then adherence and inhaler technique and the correct errors. Check for triggers and comorbidity if any. If any means any kind of allergic rhinitis or sinusitis, etc. Then short step up for 1 to 2 weeks during viral infection or exposure to allergens. Day-to-day adjustments by patients on inhaled corticosteroids as maintenance or reliever therapy. Step down if symptoms controlled for 3 months and at low risk of exacerbation. For children 6 to 11 years of age, theophylline is not recommended. Theophylline is a methyl xanthine. So for children 6 to 11 years of age, theophylline is not recommended. The preferred step 3 treatment is medium dose inhaled corticosteroids. Okay, so here in this step 3, other controller options we can add theophylline. But if the patient is of 6 to 11 years age, we cannot use theophylline. So in such cases, we need to add medium dose inhaled corticosteroids instead of theophylline. Then low dose inhaled corticosteroids or formoterol is reliever for patients prescribed low dose budesonide or formoterol or beclomethasone or formoterol. So we have completed the corticosteroids. Next we will see the alternative drugs used to treat asthma. These alternative drugs are useful for the treatment of asthma in patients who are poorly controlled by conventional therapy or experience adverse effects secondary to corticosteroid treatment. These drugs should be used in conjunction with inhaled corticosteroids therapy for most patients. Okay, so the first one is leukotriene modifiers. Under leukotriene modifiers, there are two categories. That is leukotriene receptor antagonist and lipooxygenase inhibitors. Leukotrienes, that is LTB4, and the cystinyl leukotrienes LTC4, LTD4 and LTE4 are products of the 5-lipooxygenase pathway of arachidonic acid metabolism and part of the inflammatory cascade. We all might have heard about the two pathways, that is cyclooxygenase pathway as well as the lipooxygenase pathway. The products of lipooxygenase pathway include leukotrienes, that is LTB4, and cysteine leukotrienes LTC4, LTD4 and LTE4. These are the products of 5-lipooxygenase pathway of arachidonic acid metabolism, and they are a part of the inflammatory cascade. This 5-lipooxygenase is found in cells of myeloid origin such as mast cells, basophils, eosinophils and neutrophils. LTB4 is a potent chemoattractant for neutrophils and eosinophils. The cysteine leukotrienes constrict bronchiolar smooth muscle, increase endothelial permeability and promote mucus secretion. Silutin is a selective and specific inhibitor of 5-lipooxygenase, preventing the formation of both LTB4 and the cysteine leukotrienes. Saphirleucast and montelukast are selective antagonists of the cysteine leukotriene 1 receptor, and they block the effects of cysteine leukotrienes. So the drugs that comes under the leukotriene modifiers include Silutin. Silutin is a selective and specific inhibitor of 5-lipooxygenase. Next drugs are Saphirleucast and montelukast. They are leukotriene receptor antagonists. These agents are approved for the prevention of asthma symptoms. They should not be used in situations where immediate bronchodilation is required. Leukotriene receptor antagonists have also shown efficacy for the prevention of exercise-induced bronchospasm. So the peculiarity or the feature of these drugs is that they can be used, or these agents are approved for the prevention of asthma symptoms, and they should not be used in situations where immediate bronchodilation is required. Pharmacokinetics. These agents are orally active and highly protein bound. Food impairs the absorption of saphirleucast. The drugs undergo extensive hepatic metabolism. Silutin and its metabolites are excreted in urine, whereas saphirleucast and montelukast and their metabolites undergo biliary excretion. As these drugs undergo biliary excretion, caution should be exercised in patients with hepatic impairment. Adverse effects of leukotriene modifiers includes elevations in serum hepatic enzymes. As a result, it requires periodic monitoring and discontinuation when enzymes exceed 3 to 5 times the upper limit of the normal. Other effects include headache and dyspepsia. And the saphirleucast is an inhibitor of cytochrome P450 isoenzymes 2C8, 2C9 and 3A4. Silutin inhibits CYP1A2. So co-administration with the drugs that are substrates of these isoenzymes may result in increased effects and or toxicity. Next category is mast cell stabilizers. So the first drug is cromolyn. It can be used as a prophylactic anti-inflammatory agent that inhibits mast cell degranulation and release of histamine. So the mechanism of action of this cromolyn is that it inhibits the mast cell degranulation and thereby inhibits the release of histamine. It is an alternative therapy for mild persistent asthma and is available as a nebulized solution. Because cromolyn is not a bronchodilator, it is not useful in managing an acute asthma attack. Okay, so this is the feature of this cromolyn. It is not a bronchodilator, so it is not useful in managing an acute asthma attack. Because of its short duration of action, this agent requires dosing 3 or 4 times daily, which affects the adherence and limits its use. Adverse effects are minor and include cough, irritation and unpleasant taste. So the disadvantages associated with this cromolyn is that it is not a bronchodilator, so it is not useful in managing an acute asthma attack, and also it has got a short duration of action. So this agent requires dosing 3 or 4 times daily. So this will affect the adherence and thereby limits its use. So the next drug that comes under mast cell stabilizers is ketotifen. Ketotifen is an antihistaminic reported to have mast cell stabilization activity. It shows moderate anti-asthmatic activity on prolonged use. It is useful in patients with allergy such as rhinitis, conjunctivitis and dermatitis. Unlike cromolyn, it induces sedation and dry mouth. So the main adverse effects associated with ketotifen is that it induces the sedation and dry mouth. Next category is cholinergic antagonist. These drugs block vagally mediated contraction of airway smooth muscle and mucus secretion. Drugs that comes under this category include ipratropium bromide and tiotropium bromide. Inhaled ipratropium is a short-acting quaternary derivative of atropine. It is not recommended for the routine treatment of acute bronchospasm in asthma, as its onset is much slower than inhaled short-acting beta-2 agonist. However, it may be useful in patients who are unable to tolerate a short-acting beta-2 agonist or patients with asthma COPD overlap syndrome. Ipratropium also offers additional benefit when used with a short-acting beta-2 agonist for the treatment of acute asthma exacerbations in the emergency department. Tiotropium is a long-acting anticholinergic agent, can be used as an add-on treatment in adult patients with severe asthma and a history of exacerbations. Adverse effects such as xerostomia, xerostomia means dry mouth, and bitter taste are related to local anticholinergic effects. So the drugs that comes under cholinergic antagonist include ipratropium bromide and tiotropium bromide, and this ipratropium is short acting whereas tiotropium is long acting. Next category is methylxanthines. So the drugs that comes under this category include aminophylline, theophylline, doxorubicin, etc. So these drugs are bronchodilators that relieves airflow obstruction in chronic asthma and decreases its symptoms. It may also possess anti-inflammatory activity. It is a non-selective phosphodiesterase inhibitor known to increase cellular cyclic AMP and cyclic GMP levels, which are accounted for the bronchodilation achieved. It is also responsible for its cardiac side effects. Additionally, theophylline is reported to play a beneficial role in asthma due to its ability to antagonize adenosine receptors causing bronchoconstriction, induce anti-inflammatory interleukin release, interleukin in the sense interleukin 10, prevent the gene transcription of nuclear factor K beta, prevent adenosine-induced constriction of blood vessels, inhibit histone decarboxylase 2 by its anti-inflammatory action, and increase circulating catecholamines. So the main points associated with this methylxanthines is that they are bronchodilators and they possess anti-inflammatory activity, and their mechanism of action is that they are non-selective phosphodiesterase inhibitor. They will increase the cellular cyclic AMP and cyclic GMP levels. As a result, they will cause bronchodilation. Previously, the mainstay of asthma therapy, which is theophylline, has been largely replaced with beta-2 agonist and corticosteroids due to its narrow therapeutic window, adverse effect profile, and potential for drug interactions. Overdose of these methylxanthines may cause seizures or potentially fatal arrhythmias. Theophylline is metabolized in the liver and is a CYP1A2 and CYP3A4 substrate. It is subject to numerous drug-drug interactions. Serum concentration monitoring should be performed when theophylline is used chronically. Okay, so because of this narrow therapeutic index as well as severe adverse effect profile and the potential for drug-drug interactions, this theophylline has been replaced with various other drugs such as beta-2 agonist and corticosteroids, and therapeutic drug monitoring is performed for this methylxanthines. So the last category is monoclonal antibodies. The drug that comes under this category is omalizumab. This drug selectively binds to human immunoglobulin E. So as a result, this will lead to decreased binding of immunoglobulin E to its receptor on the surface of the mast cells and basophils. So there will be reduction in the surface bound immunoglobulin E. It limits the release of mediators of the allergic response. The monoclonal antibodies examples include mepolizumab, benralizumab, and rislizumab are interleukin-5 antagonists. Interleukin-5 is the major cytokine involved in recruitment, activation, and survival of eosinophils and eosinophilic asthma. These monoclonal antibodies are indicated for the treatment of severe persistent asthma in patients who are poorly controlled with conventional therapy. Their use is limited by the high cost, route of administration. Intravenous route for rislizumab and subcutaneous for other monoclonal antibodies, and their adverse effect profile. Adverse effects include serious anaphylactic reactions, which is rare, arthralgias, fever, rash, and increased risk of infections. New malignancies have been reported. So the next respiratory disorder is chronic obstructive pulmonary disease or COPD. COPD is a chronic, irreversible obstruction of airflow that is usually progressive and characterized by persistent symptoms. Okay, so the COPD is chronic, it is irreversible. That is, airflow obstruction in the COPD is irreversible and it is usually progressive and characterized by persistent symptoms. And the symptoms include cough, excess mucus production, chest tightness, breathlessness, difficulty sleeping, and fatigue. Although the symptoms of COPD are similar to asthma, the characteristic irreversible airflow obstruction of COPD is one of the most significant differences between the diseases. Okay, so the main difference between this asthma and COPD is that in COPD, the airflow obstruction is irreversible. And smoking is the greatest risk factor for COPD and is directly linked to the progressive decline of lung function as demonstrated by forced expiratory volume in 1 second. Drug therapy for COPD is aimed at relief of symptoms and prevention of disease progression. Emphysema develops over time and involves the gradual damage of lung tissue, specifically destruction of the alveoli. Alveoli means the tiny air sacs. So in people with emphysema, the air sacs in the lungs, which is the alveoli, are damaged. Over time, the inner walls of the air sacs get weakened and rupture. As a result, thereby creating larger air spaces instead of many small ones. This reduces the surface area of the lungs and in turn the amount of oxygen that reaches your bloodstream. Okay, so this is the condition of a patient having emphysema. So what will happen in emphysema? In emphysema, it involves the gradual damage of the lung tissue, especially the destruction of the alveoli. Alveoli are the tiny air sacs. Okay, so in such patients, the air sacs in the lungs, which is the alveoli, get damaged. These air sacs become weakened and rupture, and thereby creating larger air spaces instead of many small ones. This will reduce the surface area of the lungs and thereby the amount of oxygen that reaches your bloodstream. Most people with emphysema also have chronic bronchitis. Chronic bronchitis is inflammation of the tubes that carry air to your lungs, which is the bronchial tubes, which will lead to persistent cough. So this emphysema and chronic bronchitis are two conditions that make up chronic obstructive pulmonary disease. Classification of pharmacological agents used for the treatment of COPD, or these are the classification of drugs used for the treatment of chronic obstructive pulmonary disease. So the first category is anti-inflammatory medications. So the anti-inflammatory medications can be further subdivided into corticosteroids and phosphodiesterase inhibitors. So these corticosteroids can be further divided into inhaled and systemic corticosteroids. Inhaled corticosteroids examples include fluticasone, budesonide and mometasone. Systemic corticosteroids include prednisone and methylprednisone. Then phosphodiesterase inhibitors can be further divided into non-selective and selective phosphodiesterase inhibitors. Non-selective phosphodiesterase inhibitor example is theophylline and selective phosphodiesterase 4 inhibitor is roflumilast. Next category is inhaled bronchodilators, and inhaled bronchodilators can be divided into inhaled beta-2 agonist and inhaled anticholinergics. Under inhaled beta-2 agonist, short-acting beta-2 agonist include salbutamol and terbutaline, and long-acting beta-2 agonists include salmeterol, formoterol and indacaterol. Then inhaled anticholinergics examples include, under this inhaled anticholinergics, they can be categorized into short-acting and long-acting. Short-acting anticholinergic drug is ipratropium and long-acting anticholinergic drug is tiotropium. And the miscellaneous options include antibiotics, then smoking cessation medications, immunization and home oxygen therapy. Starting with bronchodilators, inhaled bronchodilators including the beta-2 adrenergic agonist and anticholinergics. Anticholinergics, especially muscarinic antagonists, are the foundation of therapy for COPD. These drugs increase airflow, elevate symptoms and decrease exacerbations. The long-acting bronchodilators, that is long-acting beta-2 agonist and long-acting muscarinic antagonist. In short form, we can say that LABA and LAMA are preferred as the first-line treatment of COPD. Long-acting beta-2 agonists include once daily indacaterol, olodaterol and vilanterol, as well as twice daily inhaled formulations of arformoterol, formoterol and salmeterol. Eclidinium, tiotropium, glycopyrrolate and umeclidinium are long-acting muscarinic antagonists. The combination of an anticholinergic and a beta-2 agonist may be helpful in patients who have inadequate response to a single inhaled bronchodilator and are at risk of exacerbations. Guidelines for the pharmacologic therapy of stable chronic obstructive pulmonary disease. Here the patients can be categorized into 4 groups as A, B, C and D. So category A means low risk and fewer symptoms. Here the recommended first choice is bronchodilators such as short-acting beta-2 agonist or long-acting beta-2 agonist or short-acting anticholinergic or long-acting muscarinic antagonist. Next is category B. Here low risk and more symptoms. Here the recommended first choice is long-acting bronchodilators such as LABA or LAMA and recommended escalation is LAMA plus LABA. Then category C means high risk and fewer symptoms. Here recommended first choice is long-acting muscarinic antagonist. Recommended escalation is LAMA plus LABA or LABA plus inhaled corticosteroids. Then category D means high risk and more symptoms. Here recommended first choice is LAMA plus LABA and recommended escalation includes LAMA plus LABA plus inhaled corticosteroid. may consider roflumilast if forced expiratory volume is less than 50% predicted and chronic bronchitis. Next category is corticosteroids. The addition of an inhaled corticosteroid to a long-acting bronchodilator may improve symptoms, lung function, and quality of life in COPD patients with forced expiratory volume 1 of less than 60% predicted or patients with symptoms of both asthma and COPD. However, inhaled corticosteroid treatment in COPD should be restricted to these patients since its use is associated with an increased risk of pneumonia. Okay, so this disadvantage or the problem associated with the inhaled corticosteroids in COPD patients is that this inhaled corticosteroid treatment is associated with an increased risk of pneumonia. Although often used for acute exacerbations, oral corticosteroids are not recommended for long-term treatment of COPD. Next drug is roflumilast. Roflumilast is an anti-inflammatory medication. It is an oral phosphodiesterase 4 inhibitor used to reduce exacerbations in patients with severe chronic bronchitis. It is theorized to reduce inflammation by increasing the levels of intracellular cyclic AMP in lung cells. Roflumilast is not a bronchodilator and is not indicated for the relief of acute bronchospasm. Common adverse effects include weight loss, nausea, diarrhea, and headache. In COPD, the use of theophylline has largely been replaced by the more effective and tolerable long-acting bronchodilators. Inhaler technique. There are mainly two types of inhalers, that is metered dose inhalers as well as dry powder inhalers. These metered dose inhalers have propellants that eject the active medication from the canister. So patients should be instructed to exhale before they activate the inhaler and then begin to inhale slowly as they press the canister and continue inhaling slowly and deeply throughout the actuation. This is the appropriate inhaler technique and this should be properly counseled to each and every patient who are using this inhalers. Okay, so the patient should be instructed to exhale. So first they have to exhale before they press the inhaler, okay, or before they actuate the inhaler, and then begin to inhale slowly as they press the canister and then continue inhaling slowly and deeply throughout the actuation. This technique avoids impaction of the medication onto the laryngeal mucosa and facilitates the drug reaching the site of action in the bronchial smooth muscle. A large fraction, typically 80% to 90% of the inhaled medication, for example corticosteroids, is either deposited in the mouth and pharynx or swallowed. The remaining 10% to 20% of a dose of inhaled glucocorticoids that is not swallowed reaches the site of action in the airway. Pharmacokinetics of inhaled glucocorticoids. Okay, so this is the right way to place the inhaler and 90% of inhaled glucocorticoids get swallowed. So this condition can be avoided or reduced with the help of a spacer or by rinsing the mouth. So this swallowed content will enter into the GI tract, that is get absorbed from the gut, and it will undergo first pass metabolism in the liver and thereby it will produce systemic side effects. And the remaining 10% get deposited in the lung and will produce its action and thereby contribute to less systemic side effects. Use of an appropriate technique with inhaled corticosteroids reduces the risk of systemic absorption and adverse effects. Next type of inhaler is dry powder inhaler, and these types of inhalers require a different inhaler technique. Here, patients should be instructed to inhale quickly and deeply to optimize drug delivery to the lungs. So in case of metered dose inhalers, we should instruct them to inhale deeply and slowly. Okay, so in case of dry powder inhalers, we should instruct them to inhale quickly and deeply to optimize drug delivery to the lungs. Patients using any type of inhaled corticosteroid device should be instructed to rinse the mouth after use to prevent the development of oral candidiasis. Then spacers. What is a spacer? A spacer is a large volume chamber attached to an meter dose inhaler. The chamber reduces the velocity of the aerosol before entering the mouth, thereby allowing large drug particles to be deposited in the device. The smaller, high-velocity drug particles are less likely to be deposited in the mouth and are more likely to reach the target airway tissue. Patients should be advised to wash and or rinse spacers to reduce the risk of bacterial or fungal growth that may induce an asthma attack. Effect of spacer on the delivery of an inhaled aerosol. Okay, so this is a spacer that is attached to a meter dose inhaler. So large particles of the aerosol are deposited in the chamber before the patient inhales. Okay, so the large particles get deposited in the spacer and the inhaled aerosol is enriched in small particles that more readily travel to the smaller airways. Okay, so the larger particles got deposited in the spacer, whereas the smaller particles that are having higher velocity will get enter into the airways. So far we have completed asthma, COPD and their treatment options. Now we are going to learn about the next respiratory disorder, which is allergic rhinitis. Rhinitis is an inflammation of the mucous membranes of the nose and it is characterized by sneezing, itchy nose or eyes, watery rhinorrhea, nasal congestion and sometimes a non-productive cough. An attack may be precipitated by inhalation of an allergen, allergens such as dust, pollen or animal dander. The foreign material interacts with mast cells coated with immunoglobulin E generated in response to a previous allergen exposure. So the mast cell release mediators such as histamine, leukotrienes and chemotactic factors that promote bronchiolar spasm and mucosal thickening from edema and cellular infiltration. So antihistamines and or intranasal corticosteroids are the preferred therapies for allergic rhinitis. So the first category of drugs that can be used for the treatment of allergic rhinitis is antihistamines. Oral antihistamines are H1 receptor antagonists, have a fast onset of action and are useful for the management of symptoms of allergic rhinitis caused by histamine release such as sneezing, watery rhinorrhea and itchy eyes or nose. And these antihistamines are more effective for prevention of symptoms in mild or intermittent disease rather than treatment once symptoms have begun. First generation antihistamines such as diphenhydramine and chlorpheniramine are usually not preferred due to adverse effects such as sedation, performance impairment and other anticholinergic effects. So the most important adverse effect associated with the first generation antihistamines is sedation. Second generation antihistamines, for example fexofenadine, loratadine, desloratadine and cetirizine are generally better tolerated. Ophthalmic and nasal antihistamine delivery devices are available for targeted topical tissue delivery. Examples of topical intranasal antihistamines include olopatadine and acylastine. Intranasal antihistamines provide increased delivery of the drug with fewer adverse effects. Combinations of antihistamines with decongestants are effective when congestion is a feature of rhinitis or when patients have no response or incomplete control of symptoms with intranasal corticosteroids. Next category is corticosteroids. Intranasal corticosteroids such as beclomethasone, budesonide, fluticasone, cyclizonide, mometasone and triamcinolone are the most effective medications for the treatment of allergic rhinitis. With an onset of action that ranges from 3 to 36 hours after the first dose, intranasal corticosteroids improve sneezing, itching, rhinorrhea and nasal congestion. Systemic absorption is minimal and the adverse effects of treatment are localized, and these localized adverse effects include nasal irritation, nosebleed, sore throat and rarely candidiasis. To minimize systemic absorption, patients should be instructed to avoid deep inhalation during administration into the nose because here the target tissue is the nose, not the lungs or the throat. For patients with chronic rhinitis, improvement may not be seen until 1 to 2 weeks after starting therapy. Another category of drugs that can be used for the treatment of allergic rhinitis is alpha-adrenergic agonist. Short-acting alpha-adrenergic agonist, also known as nasal decongestants, such as phenylephrine, they will constrict the dilated arterioles in the nasal mucosa and thereby reduce airway resistance. Long-acting oxymetazoline is also available. When administered intranasally, these drugs have a rapid onset of action and they show only few systemic side effects. However, intranasal formulations of alpha-adrenergic agonist should be used for no longer than 3 days due to the risk of rebound nasal congestion, which is known as rhinitis medicamentosa. So the problem associated with this alpha-adrenergic agonist is that these intranasal formulations of this alpha-adrenergic agonist should not be used for more than 3 days because of the risk of rebound nasal congestion, which is known as rhinitis medicamentosa. It is not used in the long-term treatment of allergic rhinitis. As with intranasal formulations, regular use of oral alpha-adrenergic agonists, for example phenylephrine and pseudoephedrine alone or in combination with the antihistamines is not recommended. Under other agents, the drug involved is intranasal cromolyn, and this intranasal cromolyn may be useful in allergic rhinitis, particularly when administered before contact with an allergen. To optimize the therapeutic effect, dosing should begin at least 1 to 2 weeks prior to allergen exposure. Although potentially inferior to other treatments, some leukotriene receptor antagonists are effective for allergic rhinitis as monotherapy or in combination with other agents. They may be a reasonable option in patients who also have asthma. An intranasal formulation of ipratropium is available to treat rhinorrhea associated with allergic rhinitis or the common cold. It does not relieve sneezing or nasal congestion. So now we will discuss about the drugs used to treat cough or antitussive agents. So coughing is an important defense mechanism of the respiratory system in response to irritants. A troublesome cough may represent several etiologies such as the common cold, sinusitis, and or an underlying chronic respiratory disease. In some cases, cough may be an effective defense reflex against an underlying bacterial infection and should not be suppressed. Before treating cough, identification of its cause is important to ensure that antitussive treatment is appropriate. So under antitussives, the first category of drug is opioids. Codeine and dextromethorphan are opioid drugs that have antitussive properties. So first of all, codeine, it is an opioid that decreases the sensitivity of cough centers in the central nervous system to peripheral stimuli and decreases mucosal secretion. Common adverse effects such as constipation, dysphoria, and fatigue still occur. In addition, codeine has addictive potential which limits its use given increasing concerns with opioid addiction. So important disadvantage of this codeine is that it has got greater addictive potential. Next drug is dextromethorphan. It is a synthetic derivative of morphine that has no analgesic effects in antitussive doses. It is a centrally active excitatory amino acid which is NMDA, that is N-methyl D-aspartate receptor antagonist. Okay, so this dextromethorphan is a centrally active excitatory amino acid which is the NMDA receptor antagonist and is also reported to antagonize opioid receptors. It has a better adverse effect profile than codeine and is equally effective for cough suppression. In low doses, dextromethorphan has a low addictive profile. However, it is also a potential drug of abuse since it may cause dysphoria at high doses. Next drug is guaifenesin. It is used as an expectorant. This guaifenesin is available as a single ingredient formulation and is commonly found in combination cough products with codeine or dextromethorphan. Other opioid derivatives such as folcodeine and ethyl morphine are structurally related to codeine and are used as antitussive. Folcodeine is long-acting while ethyl morphine is less constipating. Next category is non-opioid cough suppressants. So the first drug is benzonatate. Benzonatate suppresses the cough reflex through peripheral action. It anesthetizes the stretch receptors located in the respiratory passages, lungs and pleura. Adverse effects include dizziness, numbness of the tongue, mouth and throat. These localized effects may be particularly problematic if the capsules are broken or chewed and the drug comes in direct contact with the oral mucosa. Okay, so the next non-opioid cough suppressant is noscapine. Although noscapine is also isolated from the opium poppy, it is chemically different from the phenandrine types of alkaloids. Phenandrine types of alkaloids means morphine type alkaloids. This noscapine acts as a cough suppressant through the non-opioid pathway. Sigma receptors are suggested to be involved in the antitussive mechanism of noscapine used for spasmodic cough. Headache and nausea are the side effects reported on its usage. The third drug is clofidinol. This clofidinol is a centrally acting antitussive having a slow onset of action along with a longer duration of action. It is reported to cause irritability, vertigo and dryness of mouth. Next drug is pranoxidazine. This drug is locally acting antitussive which desensitizes pulmonary stretch receptors and decreases the impulses arising from lungs. Due to its peripheral action, it is indicated for the bronchial cough. So the next category of drugs that can be used for the treatment of cough is mucokinetics and expectorants. Mucokinetics are a class of drugs which aid or help in the clearance of mucus from the airways and lungs. Okay, so the mucokinetics means that will help in the clearance of mucus from the airways and lungs. Such drugs can be further categorized by their mechanism of action into mucolytic agents, expectorants and surfactants. Surfactants are also known as wetting agents. Wetting agents in the sense hypoviscosity agents. Hypoviscosity means that reduces the viscosity. And adhesive means that decrease the adhesivity of secretions. Okay. So this mucokinetics means that will help in the clearance of mucus from the airways and lungs. And these mucokinetics are further subdivided into three, that is mucolytic agents, expectorants and surfactants. So an expectorant increases the bronchial secretion or reduces its viscosity, facilitating its removal by coughing and release the irritated respiratory tract. So what an expectorant will do? An expectorant increases the bronchial secretion or reduces the viscosity of bronchial secretion and thereby helping or facilitating its removal by coughing and thereby relieving the irritated respiratory tract. These expectorants do not alter ciliary bead frequency or mucociliary clearance. Examples for expectorants include sodium and potassium citrate or acetate, potassium iodide, guaiacol, guaifenesin, also known as glyceryl guaiacolate, then balsam of tolu, wasaca, and terpene hydrate are the commonly used expectorants. Next category is mucolytics. Mucolytics, from the word itself, we can understand that lysis means they are breaking or lysing the mucus or the bonds between the mucus. So these mucolytics are medications that change the biophysical properties of secretions by degrading or breaking the mucin polymers, DNA, fibrin or F-actin in airway secretions and thereby generally decreasing the viscosity of the secretions. This does not necessarily improve secretion clearance because sputum that is more viscous but less sticky tends to be clear better with cough. Some examples of mucolytics are bromhexine, ambroxol, acetylcysteine and carbocysteine. So examples for expectorants include sodium and potassium citrate, potassium iodide, guaiacol, guaifenesin, balsam of tolu, wasaca, terpene hydrate, etc. And examples of mucolytics include bromhexine, ambroxol, acetylcysteine and carbocysteine. Both expectorants and mucolytics are used to increase the output of bronchial secretions, enhance the clearance of bronchial exudate and promote a productive cough. Next one is saline expectorants. Saline expectorants stimulate bronchial mucus secretions via a vaguely mediated reflex action on the gastric mucosa. Examples of saline expectorants include ammonium chloride, ammonium carbonate, potassium iodide, calcium iodide and ethylene diamine dihydroiodide. These iodine-containing products are contraindicated in pregnant women and prolonged use can induce goiter and hypothyroidism. Then there are certain direct stimulants of respiratory secretions. Examples include volatile oils such as eucalyptus oil and oil of lemon. They are believed to directly increase the respiratory tract secretions. Guaifenesin, also known as glyceryl guaiacolate, is a centrally acting muscle relaxant that may also have an expectorant effect. It may stimulate bronchial secretions via vagal pathways. The volume and viscosity of bronchial secretions do not change, but particle clearance from the airways may accelerate. Guaifenesin is commonly available in many over-the-counter cough syrups in combination with dextromethorphan. So let's learn about N-acetylcysteine, which is a mucolytic agent. It is available as a 10% solution that can be nebulized. Its mucolytic effect is a result of the exposed sulfhydryl groups on the compound which interact with the disulfide bonds on mucoprotein. Okay, so thereby it will help in the lysis of the bonds between the mucus. This acetylcysteine helps to break down respiratory mucus and thereby enhance the clearance of the mucus. It may also increase the levels of glutathione. This glutathione is a scavenger of oxygen free radicals. Aerosolization of acetylcysteine can cause reflex bronchoconstriction due to irritant receptor stimulation. So, its use should be preceded by bronchodilator therapy. Okay, so before using this N-acetylcysteine, it should be preceded by bronchodilator therapy. That is, any kind of bronchodilator should be given, or this bronchodilator treatment should be given before this N-acetylcysteine therapy. These drugs also act as antioxidants and may therefore reduce airway inflammation. Bromhexine or ambroxol is a derivative of the alkaloid vasicin obtained from Ardithoda vasica. It is a potent mucolytic and mucokinetic capable of inducing thin copious bronchial secretion and helps in dissolving hard phlegm or mucus plugs. Side effects include rhinorrhea, lacrimation, gastric irritation and hypersensitivity. So we have completed this chapter. So far we have discussed about different respiratory disorders such as asthma, COPD and cough and their treatment options. Okay, so if you want more details or more reference, You can refer Lipincourt textbook of pharmacology as well as comprehensive pharmacy review for NAPLEX. Okay, so everyone, thank you. Thank you for watching this video. Have a great day.